Microcytic anemia is defined as mean corpuscular volume of less than 80, and there are different conditions that can lead to microcytic anemia, which I've listed here. But note that some of these conditions, like anemia of chronic disease or sideroblastic anemia, may be either associated with microcytic anemia or normocytic anemia. In any case, iron deficiency anemia is the first condition, and there are two main causes of iron deficiency. One is chronic blood loss, where in females it could be from heavy menstruation, or in elderly it could be from malignancy of a GI tract, where there would be loss of blood in the GI tract. And then in infants, since there is not enough iron in the milk, they could develop iron deficiency anemia, and thus that's the reason that infants should be supplied with the iron fortified cereals. And then the serum lab values of these patients will show low levels of iron, low levels of ferritin, and high levels of transferrin or total iron binding capacity. So ferritin is responsible for the storage of iron, while transferrin is responsible to transferring it to different parts of the body. So once the iron stores are low, ferritin, which is the storage form, would be decreased, while transferrin would be increased in these patients. The next condition is anemia of inflammation, which is caused by either chronic disease or chronic infection, and so the body has adapted itself to decrease the levels of iron in the conditions that there is chronic inflammation, and thus the serum levels of iron would be decreased, and it's being done by increasing the ferritin and decreasing the transferrin. And the rationale for this mechanism is that by decreasing the levels of iron, there would be less stores of iron for infectious agents to grow. The next cause of microcytic anemia are alpha or beta thalassemia minor, and this condition also presents with hypochromic microcytic anemia, and there could be also target cells or basophilic stippling. So different forms of red blood cells are present in patients with thalassemia. The next condition is lead toxicity, and these patients generally present with the abdominal pain, wrist drop, Burton's lead line on gingiva, and then finally they present with hypochromic microcytic anemia. And then the treatment for these patients is penicillamine, EDTA, dimercaprol, and succimer. So PEDS is the mnemonic that you can use for penicillamine, EDTA, dimercaprol, and succimer. And note that of all these medications that are available here, succimer is the one that is used for treating children with lead toxicity, and the reason for that is that this is orally available and is better tolerated in children. The next condition is sideroblastic anemia, and this could be either from X-linked hereditary disease due to the mutation in the ALA synthase gene, or it could be acquired from exposure to different chemicals such as alcohol, lead, isoniazid, or from decreased vitamin B6 or pyridoxine. And biopsy of bone marrow in these patients will show ringed sideroblasts, which is shown right here. So if you notice here, we have the nucleus, and around it there is arrangement of iron granules that is shown right here, and that's why it's referred to as sideroblastic anemia. And then lab values in these patients will show increased iron and increased ferritin with normal total iron binding capacity. And the reason for this observation is that in patients with sideroblastic anemia, the level of hepcidin is decreased, and hepcidin is blocking absorption of the iron from the gut. So since there is decreased level of hepcidin, then there would be increased levels of iron absorption, and thus the levels of iron in the serum will be increased, and the body responds by increasing the levels of ferritin as well, because that would be the storage form of iron. Now here I have the pathway for the production of the heme, and this is an important pathway that you will have to be familiar with. So if you notice, in the hereditary form of sideroblastic anemia, which is X-linked, patients have mutation in the ALA synthase gene. Lead toxicity interferes with aldehydrates and ferrochelatase, while the other two conditions are acute intermittent porphyria, which interferes with porphobilinogen deaminase, and then porphyria cutanea tarda, which interferes with the uroporphyrinogen decarboxylase. So patients with acute intermittent porphyria generally presents with the abdominal pain, psychologic disturbances, as well as port wine colored urine, but there is no photosensitivity in these patients. And then for the treatment, you will have to infuse these patients with the glucose and heme. So what heme does is that it inhibits the enzyme ALA synthase. So it inhibits the ALA synthase by the administration of heme to these patients, as a consequence of which the ALA and porphobilinogen will not build up in patients with acute intermittent porphyria. The next condition is porphyria cutanea tarda. So as I explained earlier, acute intermittent porphyria does not show any photosensitivity. But here, as the name implies, porphyria cutanea tarda have cutaneous manifestations with photosensitivity. So patients with porphyria cutanea tarda will present with the tea-colored urine, and that is due to the accumulation of the uroporphyrin. And there is also blistering photosensitivity. One other point is that patients with porphyria cutanea tarda usually have other complications, such as, for instance, they're smokers, or are drinking alcohol, or are having hepatitis C, which will enhance the blistering photosensitivity in these patients. And that concludes our discussion.